Hello and welcome to this very short presentation about occupational therapy process and how I see it and how it really is. Now, when we are talking about occupational therapy process at the university, you will be instructed of a very simple pathway where you would get a referral and then you have to get some data gathering and then you have to make some assessment, goal and treatment planning, problem identification, goal and treatment planning, and then discharge planning, and then review, and then discharge. It is really very straightforward if you follow it in that respect. However, in real life and in real life scenario, it is a bit complicated in a sense that there are a lot of things that are happening in every phase. If we simplify it, yes, there are only four phases of the process. The assessment process, phase one. Phase two would be the problem identification, goal and discharge planning, and goal setting. And then the third phase would be the intervention phase. And the last phase would be the discharge phase. So we're going to talk about each and every phase, starting with first phase, which would be the assessment. So when you are doing assessment with your patient, the first thing that you need to do is you have to establish the patient's pre-morbid functioning or their abilities prior to seeing you. If you are seeing them and you're in the hospital, so it is a contrived context. It's not a usual context. What you need to do is to find out who the person is, establish the pre-morbid functioning, find out what their occupational history, meaning what do they do at home? What are their occupational patterns and routines? Do they live in a house? Do they do their shopping? Who does their cleaning? Do they do their laundry as well? Are they a shower person or a bath person? These are all of the patterns and routines that you needed to establish. So even with this, you don't necessarily have to review the baseline medical history because as an occupational therapist, all you wanted to do is you wanted to establish and have a gist, and you need to have a picture of who this person is. What tends to happen is that if you look at the medical history, you tend to scare yourself a bit, and you then see the person as a combination of a lot of medical history rather than the person as a person. So that's what you need to do. After knowing who the person is and you've established the pre-morbid functioning of the patient, what you need to do next would be to identify their current abilities. What are they doing? And the things that they're doing, you'll find out and you'll compare that to the level where they were. That's why it is always important to find out what their baseline history is and what their abilities were. Now you need to find out what their abilities are on the current level, and you can quantify it. And there are many ways on how you can quantify it, but I have a measure that at some point I'll give you a tutorial about, and you have to just find out what their current abilities are. And these current abilities, then, you need to compare this to their baseline abilities. And if there are discrepancies, what you need to find out afterwards would be this. You need to find out what would be the impairment. What is causing your patients to not do the things that they were doing? Is it because of a contextual concern? What do I mean by that? If they are acutely unwell, for example, that's a context, that's a temporal context. Then once they become well, then they probably will be able to do the things that they needed to do. If they are freshly out of the operating theater, for example, that's another context. Or if they're in critical care, these are contexts. So there will be some things that they can do, maybe because it is the context. Was it because of a physical problem? Is their endurance impaired? Is there a generalized strength difficulty? Is it because of a cognitive impairment? Are they acutely confused? Are they delirious, for example? Or is it because of an emotional problem, in which case they could be agitated, or there is some mental health or well-being concern? So you need to find out all of these things. And this is the phase one. And this is the assessment phase, right? When you do it this way, when you assess from the top and to establish what their baseline is, this is called a top-down approach of assessment. And sometimes when we're doing assessment, we go directly into assessing the physical, cognitive, and affective component. This is a bottom-up approach to assessment, and it doesn't give you a picture of the person and in terms of their occupational history, and it will really skew up your treatment planning. So it is always advisable that you start from the top part or top-down approaches, because that's what we tend to do as occupational therapists. So that is the first phase. The next phase after the assessment, sometimes they will have some problems, these patients, but it doesn't become a problem until they have identified it to be a concern and to be a problem. So the second phase is really as important as the assessment phase. Second phase will be the problem identification and goal setting. In here, you work with the clients, you work with your patients and their family. And what you need to do is you need to establish or find out what would be the baseline target that is required for the person to leave your care as an occupational therapist. So at the onset, you are already thinking about discharge planning. You're already thinking about how you are going to discharge a person. That is because you will discharge them once they are safe enough to do these things. So you want to think about, you can set up the expectation. Are you discharging the person once they have reached independence, or once they have reached safety, or once things have been prevented, which means they are safe enough? So you need to find these things out. And you don't decide this on your own. It is a collaborative work between you, the patient, and their family. This is now the phase 2 of your OT process. Now that you have established what you wanted, sometimes in the hospital and elderly clients, it's very seldom that you will focus on independence. Although if they have gone through very simple procedure, like for example, somebody has had a stent put in their heart, that is a very straightforward procedure that involves putting in, just accessing the heart through the groin and putting in catheter. So it's only a needle stick injury. So at the end of the day, you can aim for a person to be independent, as compared to somebody who's elderly, had the fall, unpredicted fall, and they had a fracture, so they may need a little help. So that is actually problem identification and goal setting, and that is phase 2. The next phase then would be the dynamic phase, because once you have established what you needed to do, you need to think about your intervention. Are you then going to restore? Are you going to solve the weakness? Are you going to solve the edema? This is a restorative intervention. Are you going to get them to be independent with their ADLs? This is a direct ADL retraining. Or do you want to maintain their abilities, so you see them regularly so that they don't deteriorate? Or are you going to modify the situation by relying on adaptive aids, in which case you may also be preventing problems from taking place? Or are you going to create or promote, or you're going to have that supportive intervention, in which case you will be getting some type of carers to come and see the patient. So these would be the intervention that you do. So once you have set what you wanted and you have your target outcome, if you are progressing and you do the implementation, right? So you implement all of your treatment. If you're progressing towards the outcome, right, then yes, you can actually allocate and request for more time. That is if you are working in a rehab facility. So you can do that. But if you're aiming for independence and you initially set independence and you're not progressing towards outcome, then you just may have to go back again and review and think about readjusting the methods. And if your initial method was to restore, yeah, particularly if you're in a stroke ward or head injury unit or a physical rehab unit, you initially think about restorative intervention only to realize that the problems have stuck and therefore you need to compensate. So you may have to do a modified intervention now. So you then just readjust the methods then, in which case your planned outcome will have to be readjusted as well. It meant that you are no longer aiming for independence, but you would be aiming for safety. So if you're planning for outcome, then you now have a choice of moving and you're achieving it. Then you go towards the next phase, which would be there on the arrow on the right side. Or if not, if you're still not achieving it, you'll have to go back again and go back to the previous phase, which is this one, the arrow on the left side, which meant that you'll have to go back to doing some problem identification and goal setting again. All right, so it is a dynamic phase. The third phase is a dynamic phase. And so when you're achieving it, then the outcome that you would do once you discharge them, it could mean that your patient is independent. It could mean that your patient has achieved safety. You have achieved preventative aimed for prevention, and that the person is supported. So that would be a phase 4, really. So usually the intervention and the discharge, they are very much linked together. The two of them are, it's a very dynamic thing. So phase 3 and phase 4 are very much aligned with one another. There you go, guys. In summary, we have all of these 4 phases. We have talked about the assessment phase, problem identification, goal and discharge planning, and the intervention phase, and then the discharge. I hope this makes it a little bit clear for you. So if you want, you can have a snapshot of these diagram that I have rejigged. And that came from lots of textbooks, Willard and Spackman, Occupational Therapy for Physical Dysfunction. Some were adapted in Trombley, and some were adapted and that incorporates a model of practice, which is called Ecology of Human Performance as well. I hope this diagram can help you. And what you can do is you can start thinking about cases, and then you can start to put the case scenario when you're doing your discharge planning or your treatment planning. See which part of your process you are in. You can just pick and match and mix and match, if you want to call it like that. Okay, guys. Well, that's it. This is occupational therapy process and how it really is. Thank you for listening. Until next time, bye.